Okay, thank you everyone for your patience. We're going to go ahead and call this meeting to order. I think we're going to start by doing roll. Is that correct? My name is Karen Larson. I have the privilege of serving as the chair of this committee. Thank you all for joining us today. Today we're going to begin our discussion on proposed updates to the 24-27 Behavioral Health Services Oversight and Accountability Commission Strategic Plan. Since our commission adopted its current strategic plan in January 2024, the passage of Proposition 1 and the resulting amendments to the Behavioral Health Services Act have significantly changed the behavioral health landscape. These changes have created new mandates and opportunities that we must incorporate into our strategic plan. Our committee's role is to help shape these updates by analyzing the provisions of BHSA and identifying necessary refinements to the plan, understanding the Commission's unique role under the BHSA and the broader behavioral health transformation, engaging with stakeholders to ensure diverse perspectives inform our priorities, and proposing strategic updates that position the Commission to add value using its unique capabilities and levers. I look forward to a productive discussion as we work together to ensure the Commission's strategic plan aligns with the BHSA requirements and continues to accelerate transformational change in California's behavioral health system. Now we're going to take roll and establish a quorum.
Please note that under the Bagley-Keene Open Meetings Act, any commissioners who are participating remotely must keep their camera on at all times and will be asked during roll call to disclose if they have any other adults over the age of 18 in the room with them during the meeting and the nature of that relationship. Commissioners joining us online, please unmute your lines at this time to facilitate the calling of the roll. Commissioner Brown.
Present, and no one with me in the room.
Thank you. Commissioner Callan.
Here.
Commissioner Carnevale. Marking absent. Commissioner Fairweather. Commissioner Fairweather.
She's trying to say something.
Okay, now?
Yes.
Yeah, thank you. Yes, I'm here. And I have nobody's here except me.
Thank you. Commissioner Thomas Beckett. Marking absent. Commissioner Sy. Commissioner Sy.
Sorry, I was unable to unmute. I'm here.
And are you by yourself? Hello?
Yeah, I'm by myself. I don't know if I can just stay unmuted, but or have the ability to unmute. I'm by myself.
Okay, thank you. Commissioner Wilkes?
Here.
Commissioner Larson?
Present.
We've established quorum.
Great. It's now time for agenda item 2, general public comment. This time is reserved for comments on matters that are not listed on today's agenda. In accordance with Bagley-Keene Open Meeting Act requirements, we will follow all applicable laws during this meeting. As part of our commitment to transparency and meaningful public engagement, advisory committee meetings include an enhanced public comment segment for agendized items, allowing for more dialogue between the committee and the community. Please note that for general public comment, which is the portion we are in now, individuals may speak on topics not listed on the agenda. However, commissioners cannot engage in dialogue as topics would not have been agendized 10 days prior to this meeting and thus would violate Bagley-Keene requirements. That said, CBH staff will follow up on topics as needed and appropriate. With that said, Cody, can you please lead us into general public comment?
Thank you, Chair. If you'd like live meeting transcription or closed captioning, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. If there are any members of the public using translation technology, please notify the chair so that we can be mindful of that. You may request to make public comment by submitting a card in the room or clicking raise hand icon on your computer or the app, or if you're calling in by phone, push *9. Members of the public can also email us public comment to be shared at a future meeting at publiccomment@bhsoac.ca.gov. I do not see any public comments online or in the room, so I'm going to give it back to you, Chair.
Thank you, Cody. We're moving right along in this agenda. We're now on agenda item 3, our strategic plan update discussion. Really excited to have Brenda Graylish, our executive director, and Eric Douglas and Karen Bloomer from Leading Resources Incorporated to begin the presentation and facilitate discussion of the proposed updates to the Commission's strategic plan.
Great. If we could pull the presentation up, thank you so much. And I really appreciate the committee's members for coming together today for this very important discussion, and for all of our public participants who are joining us today to listen in and participate as well. So I'm Brenda Graylish. I'm the Executive Director for the Commission for Behavioral Health, and I'm joined by my colleagues at Leading Resources Incorporated, as Commissioner Larson mentioned, Eric Douglas and Karen Bloomer, who have been really helping to facilitate this process. I think we're at this pivotal moment with our commission, as we're transitioning from MHSA to BHSA, to really think about where our commission can really lean in and make some important take some important actions and really meaningfully contribute to our behavioral health landscape in California, and really seizing this moment to maximize many opportunities that are coming as a result. Just in terms of today's format for our meeting today, we've been working to come up with some proposals. We have our existing strategic plan. That's a 3-year strategic plan. It was initiated before the Proposition 1 Behavioral Health Services Act passed. And so really the approach we've been taking is to think of this as kind of an overlay, or what could be an addendum, putting our current strategic plan through the lens of the BHSA, looking at our current portfolio of work that we're doing and seeing what we can carry forward, and really what our new opportunities are for the horizon. So the first part of our meeting today is really going to chunk out on those big priorities that we talked about at our January commission meeting. We'll go in a little bit deeper, a deeper dive on those priorities to really let you guys know kind of what our thinking is, kind of what the thinking is and what the reasoning is behind those different priorities. And then go a little bit even deeper, talking about the results that we're looking to see within each of those priorities. And that'll be kind of the second part of our meeting. So we've got some slides to present, but there's really, the point is to have a lot of rich discussion with our commissioners and our public participants today, to see, get reactions and see if we're on track, or if there's any other ideas for where we want to go. Before I get started, I'll look over to my colleagues and see if there's anything else that you guys would like to add.
I think you said it well, and we're ready to get started.
All right. So let's do this. Okay. So as I mentioned, really the impetus for this is our strategic plan update. This is not an overhaul. We're not doing a whole new strategic plan right now. This is just like an update, or we've been calling it a refresh, but just really, again, looking through that BHSA lens for the work that we're doing, and really anchoring to what we're going to be able to accomplish in the next 2 years. And when we say 2 years, these are calendar years, calendar year 2026 of which we are now almost a quarter into it. It's amazing how fast time is flying. And then to calendar year 2027 as well. And as I just mentioned, we had talked about our 4 big bucket priorities at the January commission meeting, where we were looking to lean into those with the highest needs, integrating substance use disorders into our portfolio, leaning into peers and innovation. So those were kind of the 4 big category areas. We will talk about that a little bit more in depth today. And then what will be really new today is the results, and that's some of the work that we've been doing as a CBH executive team with LRI since that January meeting. Okay, so part 1 of this meeting, the impetus for our strategic plan update. I think I'd mentioned this a little bit in my opening remarks in terms of, we had done a strategic plan that is for calendar years 2024 to 2027. So we are now in February, moving into March 2026, and things are changing quickly, and we want to keep pace with that change. So that we are in alignment with Proposition 1. So, let's see, I'll go to the next slide. So just a little bit of a recall. As you guys might remember, in the January full commission meeting when we had the strategic plan update that we were talking about. We had a presentation from Sandra Gallardo, our chief counsel, who really went into the different allocations that our commission receives, and just reminding everybody that 100% of our funding is from the Behavioral Health Services Fund. So we do have broad advisory authority, but we do have very specific prescriptive funding authority. And so it's just a good thing to anchor to as we're kind of thinking about this work. The other piece of it is, that the way we've operationalized the strategic plan update is for this time-limited advisory committee that's going to be meeting very quickly over a period of a handful of months. And we've got LRI to help us with this. And so again, a big thank you to all of our commissioners who have agreed to serve on this time-limited committee. And so essentially, we did our kickoff meeting of this project at our January 2026 full commission meeting. And then once we use that meeting or leverage that meeting to establish this committee, we're looking to have 2 meetings of this committee, one in February, which is this meeting today, and then another one in April. So, and in between those 2 meetings, or I should say following those 2 meetings, are full commission meetings. So we'll have the full commission meeting in March and the full commission meeting in May, and updates from these committees will then flow to the full commission with the goal of having the full commission adopt our final work product from this committee at the May 2026 meeting. And then if and once that's adopted in May 2026, then the process after that will be for the CBH staff team to work with LRI to implement that plan. So again, I keep saying this, it's a refresh, not an overhaul. There's going to be those tendencies as we're talking to want to go into things that are bigger. We'll keep a parking lot of that though, because right on the heels of this, once we get this done, we are going to have to start thinking about our strategic plan because calendar year 2027 will be over before we know it. And we want to make sure that we have a very robust commission and stakeholder engagement process for that full new plan that would start in 2028. So for now, just asking everybody to just kind of really think that this is just a refresh, not an overhaul. We're looking to retain the existing 2024 to 2027 CBH strategic plan framework for our goals and objectives. So that framework actually does have goals and objectives. We went through a little internal exercise to see if things carry over, and they do. So so we kind of did that legwork, and so this just flows from our existing strategic plan. Like I said, we've layered these priorities, the 4 priorities, those 4 categories that we'll talk about today, and the results within those categories that we're looking to achieve. And again, another thing I'd ask for folks to keep in mind as we think about this is how we can align as much as possible our current portfolio of work within these new priorities, because we don't have new resources out of this. This is all within our existing resources. So through a lot of the work that we're doing, through some of our preliminary thinking and some of the work we've done to get to this point, there's a lot of work that we are working on that does already align with the Behavioral Health Services Act. So we'll just want to kind of categorize that as we're thinking about this, and we'll go through that today. But just being mindful to try to not add new things on that we don't have resources for. But again, we can capture ideas and think of things in the future. This next slide is a slide that we had talked about at our January commission meeting, and it's just a nice one to have handy. We've got a couple of these that are nice to have handy as a reference as we're having this conversation today, and even as we're continuing to have these conversations in our full commission and next committee meetings. But really what the changes or what the impacts were to the commission as a result of the Behavioral Health Services Act. So we don't have the same oversight role that we had previously. We don't have innovation as an innovation oversight role with counties, because innovation is now within the commission's portfolio as a part of restructuring. There used to be revenue expenditure reports under MHSA, and now there's the I think it's called the Behavioral Health Transparency Oversight and Accountability Report, or BODR. And so that's something Department of Healthcare Services is working on with counties and stakeholders. And so we don't receive those, we won't be receiving those RERs anymore. We won't be setting prevention and early intervention priorities anymore, and we don't have any more regulation authority. What we've had added, our name changed, we've got our new 11 commissioners, and really important for today's meeting is inclusion of SUD as a standalone. So again, that's why that's one of those called out priorities. And then the state level, we've got, like I mentioned, that Innovation Partnership Fund that has moved up to the state level here at the commission. And so we will be continuing that work as we're kind of kicking that off pretty soon with our RFP that just got approved at our January commission meeting. And innovation being one of the 4 priority areas as well. And then we have our consultation roles. That is something that we've had, we'll continue to have, so I guess that might go both in the added and remains categories. What's also added is the BHSA priority population, so you'll hear me talking about that quite a bit today. And then substance use disorder integration into our portfolio. And so finally, that last column in terms of our advisory role, again, we can advise very broadly, but very specific funding that comes to us for specific work. We're going to continue with our data reporting. We've got our data visualizations and our dashboards with our transparency suite. We've also got our biannual full service partnership report that we're required to produce. So I'll be talking about that. We've got some different committees that we work on, and then all of our funding streams, like things like our Mental Health Wellness Act, the Behavioral Health Student Services Act, and advocacy grants, and trying to think about those funding streams through a BHSA lens. That's what we'll need to do. Another reference slide that's nice to have handy in terms of what are the BHSA priority populations. And so slide 8 here is really showing the highest needs behavioral health populations for children and youth, as well as adults and older adults. And so I won't read off this slide, but it's things that we're really familiar with in terms of either helping folks who are at risk of or who are involved in the justice system, experiencing homelessness, at risk or involved in institutionalization, conservatorship, child welfare system, those things of those natures are really high behavioral health needs or at risk of. Next up, in terms of proposed refinements to the current strategic plan, this is another one kind of throwing back to that January meeting in terms of the considerations. I've mentioned quite a few of them already, and really the refinements that we're looking to focus in on or hone in on are, the BHSA priority populations, so those with the highest needs, SUD integration, peers and elevating peers, and then innovation, which can also involve public-private partnerships. Okay, so this part 2 is kind of going to be the meat and potatoes of this first section of our day. So I'm going to go through the different priorities that basically these 4 big buckets or categories in detail to explain the rationale for them. I'll ask that commissioners and stakeholders just jot down questions and notes as I'm going through all of this. It's going to be a little dense, and then we'll have some questions. We'll pause for questions, and really the dialogue is going to be the biggest part of this section. So if you could just hang with me through the dense portions, because it'll be a lot, but it's really important, and really want to have time for feedback from everybody. Okay. So again, I think I'm saying it's probably several times over in this slide deck, so everybody just kind of has it drilled into their minds, these 4 areas. We were calling it, I think, FSPs before, but we've really labeled it as meeting the needs of people with the highest behavioral health needs. We were calling it SUD integration before, and while we're saying ensuring that substance use disorders is incorporated throughout our work as a commission. For peers, it's expanding peer behavioral health services. And for the innovation piece, it's building the evidence base for the effectiveness of new and innovative statewide strategies. So these are kind of our broad areas, our broad priorities. So with that, diving into priority 1, meeting the needs of people with the highest behavioral health needs, We have several bullets here to explain our rationale, but really, this work is in alignment with the 14 Behavioral Health Services Act goals that have been set forth with the Department of Healthcare Services with their stakeholders. And the BHSA priority populations. We also are wanting to make sure that we're capturing housing issues. There's been a big change in the allocation structure, with housing being a big piece of the portioning out that goes of the funding that goes to the counties. So wanting to make sure we're paying attention to that and leveraging our expertise in the commission in that space. We also have, as a commission, our statutory responsibility to report on full service partnerships. So we have our biannual FSP report that's required as a result of SB 465. We also have had a longstanding role in educating legislators, counties, and providers. And so we can lean into that, focusing on the Behavioral Health Services Act and how it differs from the Mental Health Services Act. That's something that's been certainly coming up onto our radar as people are trying to adjust to the changes through the transition. Also, helping as a commission, we can offer an independent perspective on reforms and try to fill in gaps. Even though our oversight role has changed, we can still identify gaps and lift those up and provide what technical assistance that we can that has historically been unaddressed by other entities like other state agencies. And then our work is really just, again, around FSPs is just that critical driver for system accountability. Again, that's one of the other big pieces of the pie for counties as they work to implement the Behavioral Health Services Act. The second priority is ensuring substance use disorders is incorporated throughout the commission's work. So the rationale behind that is making sure that, given the complexity of this change to the Behavioral Health Services Act, we're just wanting to make sure that we are carving out or dedicating thinking and time and space to make sure that we are being thoughtful and thinking about how that is impacting the different funding streams and what coordination is required across fiscal, clinical, and administrative systems. So there's SUD integration at the local level, and there's also SUD integration within our portfolio, and all of that is relevant to the work we're doing. And again, with SUD, it's alignment with the BHSA. It's a carve out as a standalone. I should say it's a standalone, so that prior to BHSA, SUD could be included, but only if it had a nexus or an anchoring to serious mental illness. But now it can be on its own. And so really thinking about the work that our commission is doing and could be doing in this space in the future. We currently have our $20 million Mental Health Wellness Act project, which is our SUD pilot that's been going for about a year and a half now. And then also, so we've got our existing work in this space, but then we've also got future work planned, or just also as we think about our future allocations as a commission, putting it through this lens. We do have at the most recent commission meeting some of our BHSSA, our Behavioral Health Student Services Act funds that are going to go towards a SUD pilot for schools. So those are good examples of already the commission wading into these waters. And again, just our commission having leadership and expertise to be able to guide implementation of this SUD as a standalone and working to reduce stigma in this space to be able to maximize success. In terms of our third priority, expanding peer behavioral health services, rationale there is, we've played historically a significant role in advocating for peer support. And it's proven benefits in terms of outcomes, reducing costs on the system, and addressing some of the workforce shortages, and being able to provide that culturally relevant whole person care, particularly since so many of our peers are those credible messengers and kind of that bridge to get folks into services. And so wanting to keep continuing on in that vein. We've been a trusted entity to elevate lived experiences and address these workforce shortages by we ourselves through our own portfolio supporting peer-run organizations. We've got our peer respite RFP that's going to be coming out soon. We've talked about that quite a bit in our commission meetings, so we've got work in that space underway. We're also wanting to make a nod to this work, supporting and aligning with the Department of Healthcare Access and Information's workforce development efforts. So we're not wanting to be duplicative or redundant to what they're doing, but rather complement, support, lift up, and inform those efforts. And again, this is one of those legacy priorities that really just makes sense for us to continue forward. A few more thoughts on peer services. Actually, I think this might be actually, is this duplicative? Yep. I think this actually is a little duplicative. Yep. All right, so never mind. That's like I put in there twice. Okay, so priority 4. Oh, sorry. Oh, did I go? I'm going the wrong direction. Okay, here we go. Sorry. In what the version I'm looking at, it's got an extra slide. Someone must have caught that. Okay, sorry, you guys. So priority 4 is that innovation piece. So building the evidence base for the effectiveness of new and innovative statewide strategies. Historically, we've had a pretty heavy hand in innovation with the funding that had been allocated to the counties for innovation, where the commission had responsibility for approving county innovation plans. With the restructuring from MHSA to BHSA, again, that funding is no longer at the local level, but wholly rests here at the commission. We now have a statutory mandate for the Innovation Partnership Fund. It's one of our most exciting, highly visible funds that we're about ready to launch. And really, because we are that dedicated entity to innovation, we can really leverage it as an opportunity to help continue transforming the systems where it's, might be a little challenging for the state and counties to find, resources and time outside of normal operations in the delivery system, to be able to try to explore and identify system improvements that then can be adopted into the larger system to help our behavioral health system function more optimally. And again, it as part of these efforts, some of the thinking behind it is, an acknowledgement of some of the volatility of funding and things that we're even seeing right now with, budget struggles or challenges that we have right now, and even what we're seeing at the local level, or at the federal level with HR1. Okay, so that was a lot of information, but hopefully by now these 4 areas, meeting the needs of those with the highest behavioral health needs, SUD integration, and peers, and the innovation priorities are really starting to get drilled into everybody's mind as kind of like those 4 priority spaces. So with that, I will stop and open it up for questions, feedback, dialogue from the commissioners on these 4 priorities and the rationales for making these our priorities for the next 2 years.
Yes, with that, again, Karen Bloomer with Leading Resources. Welcome any questions, feedback on these 4 priorities is really the foundational focusing lens for the work in 2026 and 2027. And just to preview, after the break, we'll come back to talk more specifically about desired results in regard to each of these priorities, but first just the priorities themselves. Any questions, feedback?
And I can bounce back to slides if people want to go back to specific slides.
I can't see online to see if we have any comments from commissioners.
I'm certainly keeping my eye out for raised hands from our commissioners who are virtual, and acknowledging that Commissioner Carnevale has joined us.
I think that, these are broad enough that, we could move on to sort of, deeper into these. And that's really where my questions or comments would come up. So yeah, I don't really have any questions about the 4 broad areas.
Great, thank you, Commissioner Fairweather. Others, yes, Commissioner Cowan.
I just have a question. Under the removed column talks about regulation authority. Can you explain that a little bit?
Yeah, we used to have authority or a mandate to do regulations like the prevention, the PEI regs regulations, and that is no longer. So,
Anything else, Commissioner Callan, before I move on to
One
Commissioner
more.
Sy? Yeah.
Yes, the prevention and early intervention priorities. You know, that also, I think, as a result of focusing on the SUDs, that's an outcome, but it's not the focus now.
I think that prevention still lives in the county behavioral health world, for BHSA and preventing, but it's really trying to get those folks that are the BHSA priority population. So that's why it's really kind of important to anchor to those highest needs and think about it through that lens.
Right, yeah, that's what we talked about at the last meeting. Yep.
Yeah, you got it.
Thank you. Commissioner Sy, please.
Yeah, I mean, I think the four focuses make sense. The rationale makes sense. How would these focuses be layered on top? Is it that the current strategic plan just stays exactly the same and there's general agreement, assuming the commission kind of votes and agrees with this too, that these four layers, these four priorities would just be kind of in addition to, or are we actually going to make any changes to the current strategic plan? Does that question make sense?
Yeah. And I think we're thinking, at least with our thinking as of now, we're not looking to make any changes to the current strategic plan. This would be kind of a layer on top or addendum type of product
Got it.
to help focus it.
Got it.
That's
Okay.
exactly. If I might just add, probably unnecessarily, that if you imagine these four priorities and again the desired results that we will share later for your feedback as the focusing areas and focusing results for 2026 and 2027. So they are the manner in which and the focusing of how those goals and objectives would come to fruition in 2026 and 2027.
Thank you.
Other questions or feedback or concerns or hesitations of these four priorities? Yes,
Sorry,
Commissioner
one more
Callan.
question. With the current programs that we have in process, and then we layer this over them, so would the goal be to redirect their current process or to keep it the way it is?
Yeah, we wouldn't stop any existing projects. Existing projects would continue, so it's just kind of the ramping and moving along. And so, and actually a lot of the projects we're fit. Yeah, exactly.
So I guess just to jump on Commissioner Callahan's question, then for current projects, I mean, could we maybe not require, but ask that they try to prioritize these four elements, including SUD, into their work? Because I know that, in the past, I think I've commented on different investments or projects that the commission has invested in that have been, in the past only focused on mental health, right? And is that a possibility rather than kind of waiting until whenever those agreements expire?
Exactly. And I'd say too, we actually didn't even wait. So like good example is our advocacy grantees. We worked with them last year to amend the contracts to put the BHSA lens, and BHSA priority populations. And some of the stuff we'll be talking about today even goes a little bit further with some ideas that we can do, say, for example, with substance use disorder and leveraging them to help out more in that space as well. So yes, it's all that. I think that just to be clear about that too, we've got work in our portfolio now. We've been already trying to get that into the BHSA alignment as much as we can, and then we've got funding that we have as our current allocations, and we'll want to start thinking about those funding opportunities through the lens of these four priorities.
Commissioner Fairweather.
Yeah, I guess, one overarching theme I'm thinking of is that, 90% of the tax revenue is distributed to the counties, and that it's important that that we're careful that what we're doing is not either, redundant or something that, the county, is the county's responsibility, I guess, or, so that there is something, different and additive with regard to the activities that are funded.
Yep, absolutely.
Commissioner Sai, I see your hand.
Yeah, this comment is, I think, meant to share some of the things that I've come across in, I'm obviously involved in the state level commission, involved in our local behavioral health commission, and in our local BHSA implementation. In that, I think the focus on SUD is unique in that everything that we've talked about also applies to SUD. You know what I'm saying? Like the way that I think about the Behavioral Health Commission and BHSA, mental health and substance use are the pillars. And then everything else, peers, innovation, everything else kind of applies to both. And in that way, I would encourage us to think about SUD as being distinct and kind of uniquely elevated at the same level as mental health in all of the work that we do. I know that that doesn't happen on its own without kind of calling it out and deliberately trying to think about things in that way. And I know that it's very easy to think about substance use as similar to like another special population, right? Whether it's veterans or people experiencing homelessness or whatever. And so I just want to kind of make that comment because I think it frames what we're talking about. We're talking about adding SUD as one of the 4 priorities, but I think there's also a uniqueness to that.
Well said.
Any other questions or feedback? Commissioner Larson.
Thank you so much. This is such a great conversation. I think, it's when I think about the timeline, it's almost unfortunate that the strategic plan was done when it was, because within 3 months of it being finalized, Prop 1 passed, and within a year, we had 11 new commissioners and a new executive director. And you can't continue to operate under old rules with all of those things changing. And I think the other thing is the existing strategic plan almost reads like a series of vision statements versus a strategic plan. And so every one of us would agree with every goal within there. And they're so broad that it's and we don't have the power, the resources, et cetera, to achieve them all. So I think we have to acknowledge that. And I think the thing that maybe hasn't been spoken is when the legislation that led to Prop 1 started, the proposal really was to get rid of the commission, kind of. The commission was going to go to the state. The executive director would be appointed by the governor. There was a lot of focus on this commission in the original legislation. It didn't end up that way. And I think that was a testament to the legislature's belief that our independence is important. And every budget cycle since then, we've faced some pretty significant threats. And so this strategic plan is super timely because of the Proposition 1 and because of a new executive director and because of 11 new commissioners. And I think we also have to make sure that we are proving our value to the administration and to the state of California. And so I firmly believe that these kind of focus areas are where we need to really hone in for the next couple of years. I hear Commissioner Sai's point that in some ways by calling out SUD, we almost minimize it in a way, or put it as a separate population. It's almost like when I think about when we're talking about our different racial or ethnic groups, it's the same kind of thing. It's you want it woven through every single one of your goals. And because it's a change in this current moment, I think it makes sense to have it called out here. I just want to really acknowledge our friends from LRI and the staff, because I know you've done a lot of work to get us to this point, and just really impressed and excited about where we're going.
And I think you said that really well, Commissioner Larson, in terms of, it's get called out because it's kind of a unique thing as part of this transition, but the idea is for it to fold into everything. And I mean, spoiler alert, it does fold into everything in the second part of or third part of this this meeting. But yeah, I think even just noting what you and Commissioner Tsai have said, because even as a parking lot issue and something to think about when we do our next full strategic plan refresh of how we might want to think about that.
Any other questions, unspoken concerns, or wonderings about these 4 priorities as they are the foundation of what's being proposed, again, with more specific results that we'll talk about later? Anything else? Okay, wonderful. With hearing nothing else, I take that to mean comfort with these 4.
We can move, is there, I would say we can move to public comment then, if there's
I-
no, okay, yes.
Yeah, I'm just Commissioner Brown. I could not find, still can't find my raise your hand button here. Sorry about that. But yeah, I just wanted to bring up, we've had some discussion and some robust and frank discussion about the finances and the future and how they're going to impact us and what we can do as a commission, and indeed what California can do as a state, and by virtue of that, what the counties can do to address these 2 significant problems. And we're really at a critical juncture right now with respect to the financing as it relates to mental health and substance use disorder services. And I would like us to, I don't know whether it's to put it in as a part of an old priority, to put it in as a new priority, but the discussion that we had about looking differently at how these 2 problems and issues are funded, and how we can go about maybe trying to leverage the limited funds that we have by collaborating and partnering with other entities, other government entities, other private entities, foundations, banks, a number of different potential strategies there. One of the things that was kind of sad, I think, was that we 3 of us took a trip to London and met with a number of people from the European Bank, from foundations from across Europe, from governmental entities that are engaged in very similar work that we are engaged in. And they have an incredible amount of resources that are being put towards things that we are trying to focus on as well. And we've had this discussion, and I think there's this concern about, well, we don't have hardly any money here, so we can't earmark any money to try some different things innovatively or to work with other people. But the reality is, let's face it, the state is facing a significant structural deficit, a multi-year deficit. The funding that we have is not even guaranteed to continue in its present levels or forms. And I think that we need to really try to be innovative and look at partnering with philanthropic and other kindred type organizations all across the globe, because these are international problems. These are not unique to us here in California. And I thought we had made some really good inroads. We never really even got a chance, unfortunately, to report back on those experiences because of the tempest that came up with allegations of impropriety about that trip, which are frankly very sad. But I do think that we need to, as a commission, recognize that this is an important element of what we should be doing. And I think that needs to be part of our strategic approach to how we do it. And I realized that we talked about it. We didn't earmark any funding for the current year, but for us to even think about doing something next year, we need to be talking about it right now and not kick the can any further down the road. And I would defer and ask, Commissioner Carnevale, who's really had the vision on this for many, many months and several years, maybe to add his thoughts to that. But those are my thoughts, that we definitely should incorporate this somehow into our strategic plan.
I say that's actually going to be the part of the second thing. So we're actually looking at that under innovation. And so when we get to the second part or the third part of this presentation, I'm thinking of it as part one, part two, pre and post break, but really it's the third part in the slide deck where we'll talk about when we start going into innovation and some of the results that we're looking to see it under the innovation priority. That is something we listed there.
Okay.
Yeah, thank you.
I would only make note that at the budget committee, we did have a lengthy conversation to try to begin a potential process that Commissioner Chair Rolette took on, which was great to see. And I personally am hopeful that out of that we'll begin to see some action in that direction.
Thank you. Okay, just checking if there are any other comments or feedback from committee members before we instigate public comment. Okay, with that.
Just before we open up public comment, I want to acknowledge that we got a written public comment this morning. It has been included and is publicly available. Just wanted to acknowledge that out loud before we move into the public comment. I think Cody's going to lead us through with opening it up to dialogue.
All right, thank you. I'll go over public comment procedures real quick. For members of the public in the room, if you have not already, please use one of the green public comment cards located at the front to indicate you would like to make public comment on this item or any other agenda items. Cards can be given to staff located at the table. When it's your turn to comment, I'll call you up to the podium or unmute your line and announce your name or the last 3 digits of your phone number. We appreciate your understanding with the process. We'll start with in-room comments. When your name is called, please proceed to the podium to make your comment. First in-room comment is Sarai.
Hello. Okay, perfect. Hi, my name is Sarai, she, her pronouns. I'm a second year MSW student at UC Berkeley, and I'm an intern with Safe Passages. I just wanted to show my appreciation for everyone's work on the implementation of the strategic plan. Like all your work does not go unnoticed, and I especially wanted to show appreciation for how these 4 priorities and rationales have been approached as an additional layer to kind of focus the strategic plan. So I just want to say thank you for implementing community feedback into these things. And so my questions are mainly around the proposed priority number 1, the meet the needs of people with the highest behavioral health needs. And so I was curious, and apologies if this question is out of context, but I was just curious how that population is going to be defined. Are we going to explicitly define those populations? And I think really the concerns are just over kind of having a generalized goal and how that could leave out populations that have the highest disparities as BIPOC and queer and trans communities, which I think is something that folks were raising up. And so my questions were just around clarity about how we're going to define that. Thank you.
Good question, and we can answer those, right? Because we're right, Cassandra? Yeah, all right on. Do you want me to go ahead and take that, Karen? Okay. The BHSA priority populations are already defined in statute, so that's already there. I think equity needs to be embedded in everything that we do. So as we're continuing to think about when we move into the second or third part of this on the results, really thinking about equity throughout every single bit of the work that we're doing. So.
All All right, we'll move to the next in-room public comment. Ash, please go ahead.
Good afternoon, commissioners. My name is Ash, pronouns are they, them. I am also a graduate social work intern at Safe Passages, and speaking on behalf of Safe Passages, which is, they are part of the CRDP, which is the California Reducing Disparities Project, and REMCO, Racial Ethnic Mental Health Disparities Coalition. Thank you for the opportunity to comment. And thank you for the presentation on the focal points of this strategic plan. We just wanted to say that we strongly support prioritizing individuals with the highest behavioral health needs, SUD integration, peer expansion, and innovation. Our recommendation is that prevention and culturally responsive infrastructure remain explicitly visible within Priority 1. Many of the individuals entering FSPs today are connected to communities served through prevention and early intervention networks, and those systems are interdependent. As we anticipate CRDP funding potentially sunsetting, we encourage the Commission to consider how community-defined evidence practices will be sustained within this new framework. Sustainable system transformation requires alignment across the full continuum, and this includes both upstream and downstream. Thank you for your thoughtful leadership during this transition.
Thank you.
Okay, thank you. We'll now move on to virtual public comments. Please make sure you have your hand raised. Right now, we only have one. Jenny, please go ahead. Let me unmute you 1 second. There you go. You should be able to unmute now.
Right. My name is Jenny Bayardo. I'm the Executive Officer of the California Behavioral Health Planning Council. This comment is in regard to Priority 3. We appreciate your intent to engage in work that supports and does not duplicate the work of HCI. We also ask that you consider the work of the council related to peer support to avoid duplication, as we are also funded by BHSA and have consultation responsibilities in the implementation of peer support specialist certification and welfare and institution code. Thank you.
Thank you. And noted.
Thank you. That's all public comment.
Great. Hold on 1 second. All right. Sorry, I had to get counsel from a council. So I'm not. Well, we are very much ahead of schedule. So that's what I was trying to see if we could just keep pushing on. So, what my counsel was advising me on was that come 2:45, if we're still going, then we will need to take a break. It's what's on the agenda. But so just heads up on that. But in the meantime, we can keep pushing on. So if Cody, if you wouldn't mind bringing that PowerPoint back up again, we can start moving into the results section now. So again, anchoring to these 2 years, we've done some, the executive team here at the Commission has done some deep work with LRI to prepare for today's meeting by really kind of digging in to say, what are the results that we're hoping to see for each of these 4 priority areas. So this is where it's going to get a little dense. And so even more so than the last section. But I'm going to go through all of these, all the results that we've come up with for each of the priority areas. Again, asking you all to just kind of take notes. What I can do is I'll go through everything once to give everybody kind of a tour, and then we can go back priority by priority to have conversations to get everybody's thinking on everything, on each of these priority areas. Okay, so with that, Priority 1, meeting the needs of people with the highest behavioral health needs. We have 5 results for this area, this priority area. The first one is that the Commission will educate key stakeholders on the distinction between the Mental Health Services Act and the Behavioral Health Services Act and the intended results of the Behavioral Health Services Act. This is coming because we've had quite a few folks approaching us and confusion, and so we thought this is a place where we could really lean in and add some value to help provide clarity. The second result is that the Commission will increase transparency and shared understanding of how county behavioral health departments are allocating BHSA resources to serve individuals with the highest behavioral health needs, and this is subject to the information available to us, so for information that we can capture and compile and report on, but I think there's definitely been interest in how is the money being spent. And I will say that the Department of Healthcare Services has a good chunk of this responsibility, so this again would not be duplicative. The goal is not to be duplicative there. Result number 3, the Commission will become a trusted steward of knowledge and learning regarding full service partnerships during and beyond California's transition to a new behavioral health data and accountability framework. So like I said, this is an area where we already are doing a lot of work. We've already got a lot of work on our FSPs, and so this is how we are capturing it within these this layer that we're doing onto our strategic plan. Result number 4 is that the Commission will increase statewide understanding of the standard of care experienced by individuals served through full service partnerships, focusing on the BHSA priority populations by systematically gathering and synthesizing qualitative community-based insights. So, there's always the intent of how a system should be implemented and what actually ends up happening. And I think of what we end up hearing a lot of times is what is actually happening, and being able to capture that information and compile it and provide it out in a way that can be constructive so that quality improvement efforts can be made. And then the last one, the result number 5, is that the Commission will increase statewide understanding and visibility of how housing scarcity and housing service mismatches affect individuals served in full service partnerships, particularly those with co-occurring serious mental illnesses and substance use disorders, in order to inform policy planning and future investment decisions. I think this is another area of confusion that keeps coming up on our radar in terms of what's appropriate living situations for individuals who have these conditions, and particularly with regard to this co-occurring population, it's very challenging. So this is just a reflection of what we're doing or what has come our way there where we think we could lean in. For priority number 2, ensuring substance use disorders incorporated throughout the Commission's work. We have 4 proposed results here. The first one being that the Commission will continue our efforts to expand medication-assisted treatment providers and help strengthen county infrastructure to support effective, scalable MAT implementation. I think this is already our SUD pilot that we have, so we will continue that. And I think just there's a lot of learning that's coming from that project that's very rich and able to help inform the broader delivery system. So again, that I kind of think of it as a petri dish where we can kind of take things offside, can petri dish it for a little and get it back online to the larger system to help with improvements. So we'll continue that work. The second result is the BHSSA project that was just approved at our commission so that we would support the integration of SUD identification and treatment services into school-based behavioral health programs in order to improve timely access to care for children and youth. A third one would be for the Commission to increase local level understanding and acceptance of evidence-based substance use disorder treatment by supporting community-based advocacy to address stigma, misinformation, and philosophical resistance within local SUD systems. Again, another area that's come to our attention or been put on our radar, so we thought we could help in that space. And then finally, for result number 4, that we would work to increase statewide understanding of the substance use disorder treatment landscape in California to inform more effective integration of the mental health and substance use disorder care across the public behavioral health system. So again, just kind of a lay of the land landscape. Moving along for expanding peer behavioral health services, we'll continue to support the expansion, visibility, and appropriate use of peer-run and peer-owned behavioral health services. And again, this is our peer respite project that we have currently about ready to launch an RFP for. And another piece that's come up is that we would elevate and strengthen the role of peers in serving individuals with substance use disorder and serious mental illness conditions, including through education and training. So this is another place where our advocacy contractors could be of great support for that. And then finally, priority 4, this is our innovation. So building on the evidence base, or build the evidence base for effectiveness and new innovative, statewide strategies. So we have 3 results for this priority. The first one being that we would uplift best and promising practices and sustainable strategies through our Innovation Partnership Fund grants. So again, we're about ready, we're preparing to launch our first round of Innovation Partnership Fund grants, and being able to take the learnings and what's coming from those and really lift that up. Result number 2 being that the Commission will seek to advance behavioral health priorities beyond the constraints of BHSA, funding through feasible and mission-aligned public-private partnerships. That's been another piece that has come up in a variety of our meeting or several of our meetings, and so being able to explore what that could look like and how to do that within the mandates and the requirements of the system, of the public systems. And then the third result being that kind of to what Commissioner Brown was just saying in terms of that exploring strategies for ensuring long-term public behavioral health system revenue stability. So that's where that has been characterized. So committee discussion on the results that we're looking for each of these priorities. The questions we're looking to garner feedback on is, any questions that you have about the results that I've just presented on. Are they the right results? Is there anything missing? And again, I'll just say on that caveat, if there's anything missing, we don't have new resources. So if there's something missing, and we do have resources to do that, we want to definitely think about that now. If not, we want to capture it for our parking lot. And then just globally, what do you think about this approach of adding priorities and results as an additional layer to focus the strategic plan? So just kind of an overall way that we're going about doing this work. So with that, how about I go back to priority 1? And
I think that's a great plan, and thank you for that great presentation. And so I think we're going to turn now to questions from commissioners. I see some hands up online already. Again, we're going to focus on questions about priority 1 first. And so, Commissioner Fairweather, can I start with you, please?
I think Commissioner Tsai had his hand up first, so if, I can defer if it matters. Okay, so in this one, one thing that raises a little bit of concern is the result number 3. And granted, I am one of those new commissioners, but I've seen that there is some funding for like technical assistance for the counties to run their FSPs. And there's just something in me that, thinks that if the counties are getting 90% of the funds, that that should be included in those enormous budgets that they're getting compared to others. Be that as it may. The other one is I'm very much in support of result number 5. While I am the veteran, I'm in the veteran seat. I work with homeless veterans, so and mentally ill and other things. But so the housing and the services that are required to allow people to retain that housing. So not just treatment, but permanent supportive housing is something that is, very near and dear to my heart, and so incredibly important. Otherwise, you're just on this constant cycle. So, that's and I guess the other thing, and this sort of bleeds into the discussion of SMI and SUD, that in some cases they're separate in terms of diagnosis and treatment, and in some cases they're, very much enmeshed. A symptom of PTSD is substance abuse. So they're like, so, you cannot separate them. So I guess like particularly in like environments of housing, um, how that's applied and that the populations, might not be um have the same degree, the same mix or one or the other, and how we address that. So I hope I'm not rambling, but that's my comment.
Oh, I was going to say, Commissioner Fairweather, this is Brenda Graylish. So I think you're exemplifying the reason why we put number 5 on there of like how like confusing it is and how there's a lot of the considerations, and I think it's really confusing out there for those folks who are operationally on the ground doing this. And so through result number 5, we're looking to see what we could do to bring some clarity in that space or start working towards that. So I appreciate you saying that, because that's exactly kind of the thinking of why that even is a result on the slide, right? Exactly. So, excuse me. Can we go back to number 3? Because I wasn't quite tracking what you're thinking or what your concern was on number 3. And maybe I'll just say just a real quick thing in terms of number 3, that the idea is that the commission will become kind of the experts or like a leading expert on FSPs and really understanding FSPs and kind of knowing them inside and out. So that's the thinking behind result number 3, but I'm trying to tie that to what your concern was. And so I didn't know if it was maybe I needed to explain that a little bit more, if that would help help your concern, or if there's something else that you have or something that you have a concern about that I'm trying to wrap my brain around.
Commissioner, you're muted. Commissioner Fairweather, you're muted.
Sorry. We have to know, and understand the systems. And of course we want to be, improve them and guide them. But there were some grants that we were reviewed in, since I've been on, that were sort of funding the technical assistance for them to stand up the FSPs. So supporting the county's finances, and maybe I'm just wrong about that. So yes, we need to be experts. We need to know, how they're working so that we can see how they are really interacting with the priority populations and whether they're meeting them. We can help, the community-based groups and the population-based systems really be served by them. Again, veterans have been incredibly underserved by BHSA funding in the counties. So, how can the FSPs improve in order to meet the needs of all the populations and all the priority populations, and youth, and so that's important. Sort of the technical issues about standing them up just doesn't seem to be something that we should pay for.
Yeah, it's not coming to my mind on what it was that we paid for, that counties had a responsibility to pay for. I mean, the only thing that I'm tracking that we've done is our most recent, our FSP RFP on a performance management technical assistance contract, trying to help counties work with their providers to use data for quality improvement processes. So we were just, but not actually standing anything up. Like they're already required to have these data and collect these data, and they're already funded for that. So we weren't looking to fund that. We were just looking to fund supporting them and using those data for quality improvement. But I think maybe out of the larger thing of what you're saying is we should be mindful not to, fund things that there are already obligations elsewhere to be funded, which I think is an important overarching thing that we want to make sure to keep in mind as we talk today, but even as we think about our projects moving forward.
Yeah. Yeah, good. I think that clarifies.
Great.
Great, thank you. Commissioner Sai.
Yeah, so for priority one, my main comment would be focused on result number 5, which is that when we talk about housing, I think it's not ideal to focus particularly on co-occurring SMI and SUD. If we're going to call that out, I think my concern is we have recovery housing that is not always for co-occurring populations, right? It can be for SUD only populations. And actually, when you think about resources for the housing system, which right now is more strained than ever before because of some reductions in terms of housing funds, it gets very specific in terms of what services you would want to layer on top of housing for co-occurring populations versus, what's available in SUD only populations. So I would just be mindful of kind of calling that out, or at least maybe just being clear that when we talk about housing, we're talking about the full continuum inclusive of recovery housing. That's actually, some of my comment bleeds over to the second priority. But I do think that recovery housing is important to highlight. Oftentimes it's overlooked. And I'm not saying that we shouldn't support housing first. We should support housing first as well. But if you look at how housing systems across California are constructed, the recovery housing beds are few and far between compared to other types of housing. And then I'll save. Oh, and then just to address Brenda in your last question, I think it was kind of like a general question about, layering on top. I mean, I agree with Chair Larson. It certainly makes it more complicated to, know we have a strategic plan. We have this additional layer on top that is supposed to kind of all be in one, even though they're in two, right? So, but I also, sounds like we can't really do anything about that. So, I don't know what the expectation is of that question. I think it's suboptimal. I think it would be great if the timing were different, but we're in this situation. I think to the greatest extent we can, it'll be incumbent on the commission to hold itself accountable to think through a behavioral health lens, right? On everything that we do, every initiative, every project, every investment. And again, like in my experience, that just doesn't happen by itself without deliberate focus. And yeah, I'll hold my comment for priority 2 once we're there. Thank you.
Thank you.
Other commissioners with questions about the results under priority 1? Yes, Chair Larson.
Actually, I kind of want to riff off of what Commissioner Sai just brought up, because when we had our planning call for this meeting, Vice Chair Fernandez was on that call, and this issue came up. Like, is it a separate, our recovery residences a separate kind of item under priority area 1, or do we add something else under priority area 2? And so I'm struggling with that. Like, is your recommendation to adjust this result number 5, or would it be to add an additional result under priority area 2?
That is a great question, and I was thinking through the exact consideration. I think for a long time now, I've wanted to get the housing system to view recovery housing as part of its continuum. I think the tendency has been to view, the current housing continuum, emergency shelters, interim, permanent supportive, and then recovery housing is more of a behavioral health system thing, right? I like to think of it as part of the housing continuum. So if we stay consistent with that, then that would suggest that we edit result number 5. However, I do want to, this kind of bleeds into priority 2, which is, I think that priority 2 is too focused. If you look at all of the results, they're all focused on treatment. And I think that we have to acknowledge that there's substance use prevention, there's harm reduction or risk reduction, there's treatment, there's recovery housing. When we think about the SUD system, we think about it through those 4 kind of pillars. And I would encourage us to broaden our focus, especially if we're going to be pulling out SUD in this way and not really kind of being able to treat it as the pillar that I talked about in a prior comment.
Thank you, Commissioner. On priority one, just sticking with priority one, are there any further comments from commissioners in the room?
Got some questions.
Go ahead, Commissioner Wilks.
So for housing, we're not responsible for the housing component of Prop 1, right? Okay, so I wonder how that evaluation and who we need to work with to make sure that.
It's difficult to hear you.
Can you hear me now?
Yes.
Good. All right, so the housing isn't under our purview, so just wondering how we will address and tackle that amongst the other priorities here, because then I go to, I'm gonna flow real quick. When it comes to the FSP, we do have responsibility over that, right? But then there's also other components that benefit FSP, such as Medi-Cal, right? And so we need to have that comprehensive understanding of how the two match, and if there is any funding that is generated based off of that partnership to support those individuals that are in FSP. And of course, I know that there's children and youth in there, so that's what I like to see. And then when it comes to, again, back to the housing part, we're focused on homelessness and reentry and foster care. And for those that need housing, which is extreme right now, how are we, again, going to gather what information we need to maximize the funding that we input into the systems that both serves the young person's behavioral health needs and their housing needs? And as previously discussed, when you have the recovery beds, right, we know that housing is a need, and that transition from recovery to a more stable housing really can also disrupt a person's life to then go back into that cycle, which then they need that recovery services or supports again. And so just elevating that also with the DHCS's housing rental assistance. How is that going to impact? Because it sounds like there's a lot of components in here that are out of our purview, but it's going to impact the results that we have, especially when it comes to priority one.
Okay, absolutely, all that. And then in terms of result number 5 in particular, it's an educational result. So it's like trying to just promote, and even for ourselves, as a commission, we have not gone into the housing space much or at all, and we have Commissioner Contreras now is on our commission as our housing expert, and with the allocations now splitting up where housing is a big piece of the behavioral, is kind of the rationale or thinking that, what can we do in this space, both to help with our result number 2 and help others, have to do the work to achieve result number 2 in terms of good outcomes. So, yeah.
Thank you for those comments, Commissioner. Are there other comments or questions from commissioners in the room? Commissioner Callan.
Hi, I think this is really exciting, seeing these 4 priorities and the clarity and the amazing work you did. Then my thoughts come into, how is this implemented? How is this going to show in our actual commission meetings? Are we going to break things down in the meetings to priority 1? How are we doing? Priority 2, how are we doing? And how are we going to implement each of these things so we stay on focus and don't drift off into the atmosphere and fall back into the same problems that we've had in the past? I mean, you know what I'm saying. So,
well, I mean, this is certainly something we're talking about with Brenda and her team right now, Commissioner, that if, in fact, the Commission endorses these priorities and these results, and this becomes the focusing lens of this strategic plan, just how important it will be to continually be monitoring, are we achieving these results? What data do we have to show and prove to the commissioners that we are achieving these results? And really make that the focus of the commission's meetings.
And, oh, go ahead. I was just going to say, just adding on to it, so, for our future meetings, some of the other work that we're working on is, we're calling, what you're saying, we're calling it strategies. So like, what are the strategies? What are the things that we're actually going to do to achieve these results within each of these priority areas? And so that's something that we're working on right now. And, this meeting here is going to help inform that work. And that'll be largely part of our April committee meeting for the Strategic Plan Advisory Committee, is to go through all of that with committee members. And then if and once the strategic plan gets adopted in May, then that last part of the work is the implementation plan. And so that's where then LRI works with our commission staff team to come up with an implementation plan to say, okay, well, how does this look in our work and how does it show up in our commission and committee meetings?
Oh, yeah, I was just going to say the Innovation Fund frameworks that have been drafted is really taken the focus to a specific, and it's been very effective. And I could see this on a larger level, and it's pretty exciting.
Great, thank you.
Oh, where'd you go? Just to respond, with the housing once again, one, totally agree, Commissioner Sy, with the continuum. And there's, there's recovery, there's treatment, there's transitional, there's permanent, there's site specific, there's scattered housing. So how programming or treatment or ongoing, the ongoing engaging you need, particularly with SUD, is delivered in those environments can be very different. So, if the wordsmith is, adding the housing continuum, and, also that just philosophically, housing is healthcare. And not having housing or having unstable housing is extremely damaging to mental health and impact on drug use. There are the areas that we don't have control of. I mean, both Chris's organization and mine, operate housing. The bricks and mortar, the operational expenses come from different sources, Home Key Plus, etc. But the services and the delivery of and creating accessibility to mental health treatment, substance treatment, navigating systems, that is happening through community-based organizations and, the county's FSPs. So I think, that's how you sort of divide up those categories.
Thank you, Commissioner. Are there other comments from within the room or from other commissioners online that wish to speak?
Yes, because we're trying to understand the complexity of how we got here. Granted, I've done some research and could really just stay on that topic of how did we get here for a long time. But with that, I would love to know if there is any thoughts on the cost for the adults and the cost savings from the serving youth perspective. Meaning on that continuum, we have adults in care that may have gone through varieties of systems. How much did that cost up to this point? And then when we serve the youth right now, what could be the cost savings there? And then also being mindful of, I don't know, what is it called? When you get to, let's say, 2030 and the cost goes up, cost of living adjustment. There we go. So if that can be a part of whatever research or with the valuations that we're doing here, how do we anticipate moving into that layer? Because I know we'll have a further discussion on long-term impacts in generating funding to serve the populations here under BHS OAC.
I mean, that's huge. Like, that's such an important question to ask. I think there have been some studies that have been done, but it's been a while since I've seen the literature on that. But yeah, I think in terms of what we're working on, and I'm not quite, I guess I'm just hesitating because or just like stuttering because I'm like, that is so big, Commissioner Wilkes, it's such a big thing. But it almost makes me think, like, what could we do now? But then also what could be like a parking lot item for like a bigger thing. So I think it's good that you raise it so that we grab it and kind of think of it with what we're trying to do in terms of cost, and then think about that big piece of it, you know, when we as we move forward. Yeah, thank you for raising that.
Commissioner Larson, Chair Larson.
I think this comes up a lot, especially as we're thinking about like FSPs, and we know they reduce hospitalization, incarceration, and homelessness, and that saves people money, or high fidelity RAP on the youth side, right? We know that's saving lots of resources. I think this might be one of those areas where DHCS might be the holder of the answer versus the commission. Just they're the payer, for lack of a better term, and we're more of an overseer. So like that we could oversee or have input on how those services are being provided with like with the FSP contracts that we just issued, to ensure that there's high quality and they're moving towards those outcomes, but that the financial piece and monitoring really lies more with Department of Healthcare Services versus us, I think. Is that right?
Well, definitely the accountability to, you know, if this is the requirement, is that being done? So like to the extent that, you know, say we're implementing, or there's a requirement to implement something that's evidence-based that has already been shown to that if you do this, it will result in these savings, and making sure that what is being required is actually being done, that would certainly be DHCS. I think when I hear what Commissioner Wilkes is saying, it's a big study. Like, I mean, I almost think of like a university doing some sort of a study like that, where like I've seen things where it's like with foster youth, you know, and, you know, looking at data into this justice system. So, you know, matching to see like what's happened. And if you invest in certain resources to really support our foster youth, then you can avoid, you know, what costs in terms of monetary outcomes and negative life outcomes. So anyway.
Thank you. Any other commissioner remarks in the room? I do see Commissioner Fairweather, your hand is still up. Is that a real hand? Okay. I'm not seeing any other commissioners with hands up. This is on priority 1 still. I think we can move on then to priority 2 and questions. Well, are we doing public comment after all 4 priorities are discussed, or on each priority?
I was just thinking we would maybe do it after each one, because you know it kind of might, yeah, it's fresh. Okay. Yeah, and it seems we're a little ahead of time. So, do we have any public comment?
Cody, is there any public comment?
Sorry, couldn't get my mic to work. No, I am not seeing any online, and I have not got any comment cards from the room. So I think we are good to keep moving forward.
Great. Well, then let's move to priority number 2.
Great. So we'll keep our eye on the clock for a 2:45 break. But until then, we'll, if we could look at the slide for priority 2 results, these 4 proposed results for priority 2 on the next slide. Thank you so much. Okay, questions and feedback. Chair Larson.
I was thinking to what Commissioner Tsai brought up, that maybe these were a little too treatment focused. I am wondering if, when I look at like 3 and 4, I think they go a little more upstream, but I'm wondering how we could adjust these. I'm especially want to listen to Commissioner Tsai on this one because of all the work that he's done in LA that has reduced overdoses by multiple percentage points. And so I just want to make sure that we get this right and that it's something within our purview, I guess, at the same time. So I'm trying to, I guess I'm asking Commissioner Sy to say more.
Yeah, thank you, Chair Larson. I mean, there's a couple of different options that we could take. One is instead of referring to SUD treatment, which is typically the way that it's referenced right now in priority 2, we could refer to the SUD service continuum, right? When I think about the continuum, again, it's prevention, harm reduction, treatment, recovery, housing. We could also call it out in that way if we wanted to, just kind of depends on how specific and clear we want to be. But that would be my suggestion in each of these. And I do think that it's worthwhile to call out harm reduction because these are local dollars. We know that at the federal level, there's a stance on harm reduction. I think to the maximum extent possible, there's a desire to defund harm reduction from the federal level. So just in terms of meeting needs, that would be helpful.
Thank you. So I'm hearing suggestion to replace the more specific reference to SUD treatment to SUD service continuum and also specifically call out harm reduction, which is in that continuum. Okay, thank you for that. Other feedback on the results in priority 2? Or questions for better understanding?
Just a comment. I completely agree, Commissioner Sy, and also I defer to your, greater knowledge on SED, but that also overlaps with the housing because harm reduction is under attack and housing first is under attack, and there's just going to be a lot of need there. So, just a comment.
Thank you, Commissioner Fairweather. Any other feedback or questions on the priority 2 results? Without hearing it, I take that to mean you're feeling comfortable with them, you understand them. Again, the suggested amendments we've heard thus far. Anything else? So if that's so, hearing nothing else, Chair Larson, may we just check if there's public comment then on priority 2 results?
Do we have any public comment?
Okay, I'm not hearing any and not hearing from Cody that he's received anything. I wonder, shall we move on or should we sort of take this break a bit early? Is that all right? I'm seeing nods are okay. Perhaps we do that. And is it a 10-minute break?
It is a 15-minute break.
Excuse me. So Chair Larson, would a 15-minute break starting now be okay?
Yeah, that sounds great.
All right, wonderful. See everyone back in 15. Thank you.
Thank you. So we've got almost everybody back now, but we have enough for quorum so we can get started. Thanks so much, Chair Larson. So if we want, I think we left off on priority 3. So Cody, if you wouldn't mind bringing up priority 3 on expanding behavioral health services at slide 24. Let me put my eyes back on and open it up for commissioner discussion.
Yes, any commissioners with questions about the results under priority 3? Looking for either comment in the room or commissioners online who might have questions about these results under priority 3. So Commissioner Sy, I see your hand is up.
Yeah, just to summarize, so it looks like the focuses here are number 1 on peer-run programs, and then number 2 on services provided by peers. I'm aware of peer support specialists, but I'm also not necessarily an expert in peers. I don't know if other commissioners here have a better sense of, is there a spectrum of peer priorities and focuses that are not included in these 2 results, or is this pretty expansive and inclusive of all those? This is, I guess, more just a question for everyone, just to make sure that we are kind of capturing everything we need. Thanks.
Culturally concordant workforce under peers must be highlighted as part of the equity work that this commission is looking to take on.
Mm-hmm. Culturally concordant and culturally competent, is that similar language?
No, culturally concordant. Culturally competent could mean that, someone has an understanding of a culture, but not the lived experience. We want both, if not both, leaning towards those with the experience because it builds the trust necessary to get the supportive services delivered as quickly and with the high quality and with the high fidelity as possible.
Thank you. Yeah.
And I'll say too, in terms of these results, they're in alignment. This is reflective of work that we have in our portfolio, at least with result one, with our peer respite opportunity that we're going to have coming up soon. So we wanted to capture that and fit it within this framework. So that's really what result number one is going to be. Result number two came out of just really wanting to make sure that our peers, our kind of specialty peers, being able to have the competencies needed to support the BHSA priority population folks, because they need to have those competencies to be able to be empowered to do that work and also to be effective in doing that work. And so it's come across our radars quite a few times that there's opportunities for growth in that area. So trying to think about what we can do to help promote that. Is like the workforce piece is not necessarily under us because it's with HCI, and DHCS has some of it and with some of their contractors, but we can think of how that we can plug in.
I would just.
Go ahead. Sorry.
Peers are absolutely vital to the work, but I don't limiting it to peer run or peer owned. Peers, can serve in organizations that are not necessarily peer owned or peer run, but serve that group of people. They're vital in my work, in our housing and in delivery of service. So that seems sort of limiting of where the peers are, and that peers need to be embedded throughout systems. And then with regard to the workforce stuff, yes, I think with the workforce development piece, which is healthcare services, I think. Peers are within their portfolio. I guess just that, we should ensure that we, coordinate and try and leverage as much of what they're offering into the growth of peers. And another point too is building the workforce. Many peers then want to go on with their education, go on and, get many other certificates, go get go to get a master's in social work. And so supporting that as well.
Sure. Do you want to respond, Brenda?
Oh, I was just going to say, yeah. So just if it helps to clarify, the results here are really, I think there's the piece of it of like, yes, peers would be everywhere. And that's kind of how we think of our work. This is for what work we have in our portfolio. So this is what we're doing. So peer run and peer owned, that's just how our peer respite project is being kind of set up. So, or it has been set up because we voted on the RFP already. And so, anyway, so that's why you're seeing that specificity there, because it actually is representing kind of another project, which is why it's a little tricky to talk about the results. Our April meeting will go into the strategies, so it'll give more detail as to what the specific work is that we're doing it. But so I'm just kind of giving you a little deeper dive into kind of what how we're planning to operationalize that result. So,
yeah, I mean, I guess that in the strategic plan, though, it's not limited to we are funding this project, we are funding that project. It's more of, our overarching goals. So, to have it tied to a specific existing activity so tightly, I'm not sure if that's necessary, but I differ.
Yeah, and also maybe it's so helpful. Our strategic plan does have the broader in it, so that's why we have our broader strategic plan, and this is kind of more that overlay. So so that's why you're feeling the more detail-y types of results, priorities and results, because this is how we're operationalizing that to produce work, focus the work that we produce in the next 2 calendar years. So, but it is captured, as is equity too. Equity is
Okay.
overarching strategic plan as well.
Great.
Yeah.
Commissioner Callahan?
Yes, I think you answered the question, but I think under result number 2, that's just elevating. I mean, we could do that in our marketing and in our different areas and make people aware of it, and that might just be our responsibility. But I also think that number 2 seems to show that we're going to pay attention to it and see where it's embedded, and it can be embedded into people getting out of prison and doing that. What the other Commissioner Wilkes was saying. So yeah, I think it covers it. I get it.
Thank you for calling that out. Yes. Other comments? Yes, Chair Larson.
I'm wondering, I'm thinking back to like our focus on FSP and FSPs being 35% of the budget in Prop 1 at the county level. And I'm wondering, and we know peers are supposed to be included in those FSP teams, and that they're reflective, the peers should be, in theory, reflective of the priority populations. I'm wondering if there's an opportunity for a result 3 here that kind of threads that needle. I think it would get to Commissioner Wilkes' kind of point about our priority populations and about peers reflecting our priority populations, and align with our focus on FSPs in having peers as a part of those teams.
I almost think, as you're saying that, I'm thinking.
Or maybe that's a strategy.
Well, no, I was actually thinking, I mean, we have result 4 under priority 1, which is, increasing statewide understanding of the standard of care. And that's what it kind of sounds like you're talking about. It's like peers as a standard of care. And then are these peers trained and able to support that population? So maybe there's something we can kind of spin off on that, or it would be kind of embedded in that result number.
I mean, I think what I've heard from some of the members of the peer community is they're hearing at the county level that they're being cut out in Prop 1. And I mean, with FSPs being 35% of the budget and with peers being a core component of FSPs, I just wonder if we could say more either here or maybe it's in the FSP item.
Thank you, Chair Larson. I'm looking for other comments, either online or from commissioners here in the room with regard to priority 3. Not seeing any hands online, and I'm not seeing anybody with a hand raised here in the room. Chair, do you want to ask for public comment on this priority, these results?
Sure. Cody, do you want to open it up for public comment?
Sure, but sorry about that. At this time, I do not see anyone with their hand raised or any in-room public comment.
Oh, see one person.
Looks like you may have spoke too soon.
All right, one moment.
Need to unmute. No. Cody's working on it right now.
Okay, Laurel.
Hi.
Please go ahead.
It's not cooperating here. Okay, you can hear me now, right? No?
Yes.
With regard to peers, at the previous meeting this morning, which ran over and will be, I guess, separated into 2 different videos online, the listening session is what will be the name the second video that happened after 12:30. It had started, though, earlier with a panel presentation by Katera Aslami, who many of you know as a former member of the commission, and two others. And I would suggest that you listen to that because they did a very good job of presenting the current situation of peers, peer-run organizations, and entities that hire peers. It's a very difficult situation. One organization or county is going to be cutting 200 peers from their list of employees. I cannot see how the clinicians who are not, by and large, in this state, speakers of the languages or familiar with the cultures or are members of the cultures of in the way that the peers have become, even though that didn't start out that way, maybe. It's very, very diverse now. So, but they did a very good job. Listen to what they said. It seems to me that the commission could take on supporting this workforce, or not supporting them financially directly, but thinking through how this difficult transition could be shaped to allow peers to continue in their profession. That's really the main thing that I think you could do. Thank you very much. I didn't introduce myself. I guess I should. Laurel Ben Hamida, Mass Social Services Foundation, and REMCO, the Reducing Mental Health Disparities Coalition. Thank you.
Thank you, Laurel. There's no more public comment at this time.
Yeah, thanks, Laurel. And I'll just, for our commissioners, so that everyone can understand, this morning we had our CFC meeting, where it was that third meeting of the CFC to decide whether or not they stay separate or come together. And then as part of the second part of that meeting, was Commissioner or Chair Chambers held some space for some of the for peers to come and publicly state what's happening in the peer space with the changes from MHSA to BHSA. So I think that's what Laurel was suggesting, is grabbing some of that information and having that inform our thinking and work as we're moving forward.
I think that's exactly the point I was trying to make. I wasn't making it very well, but I think we know we have a dramatic behavioral health workforce shortage, and we know peers are at the foundation of that workforce, whether they go up in the career pipeline later or not. But we also know that they are the best representatives of, you know, having been system involved or, you know, being of different racial ethnic backgrounds. And they represent the people we serve better than anyone. And so it seems odd to me that there's this, where all these peers are going to lose their jobs in the midst of a behavioral health workforce shortage, when the majority of the funding needs to go to models that literally fund people with lived experience. So I think anything we can do to help educate the public and grow the peer workforce and support the peer workforce, I think we should.
Okay, with that, we'll move on to the fourth and final priority and its results. Priority 4, if we can move to that slide. Executive Director Graylish had already reviewed these 3 results, and now we'd like to know, what is your feedback? Do you have questions for clarification? Do you have suggestions? Does silence mean complete understanding and support for these, or is someone harboring a thought or question? And if you are supporting these, we'd love to hear that as well, please.
I'm just, can you put I'm just thinking of the how, but I know that's not this meeting. For example, result number 2, we've talked about it, it's great. Okay, what's the next step?
All right. I'll chime in here. So, there's been a lot of discussions over my time here from April, and I would like to say April and now, April, the past, I'd like for us to all move on from. Unfortunately, it keeps coming up. With that being said, when I think about sustainable funding, considering we're an independent body, I appreciate the global perspective, but America is the largest economy. And if we can advocate, have we advocated at the federal level? One. Two, when it comes to what I spoke to of how we get here, there's been a lot of players in the space of generating revenue. And some of that has been at any cost, which includes human lives. With that being said, innovative opportunity is there someone we can charge with supporting this work ongoing? As an example, when the opioid situation happened in that huge, what was it, $55 billion settlement, how much of that did we get and how are we using that, right? Those are the things that I think about in regards to generating some type of revenue. And then when it comes to the stipulations of building up what we got, I don't want to build it with the benefit of millionaires who were taxed initially from Prop 63 to benefit, because to me, that sounds like a net zero opportunity. I'm not about that life. So with that, those are the three areas in which I see us moving forward and exploring for how we can stabilize funding. And again, I will mention, America is the largest economy. That advocacy that we can do here at the state level, how are we doing that at the federal level?
Thank you, Commissioner Wilkes. I see Commissioner Fairweather's hand. Please go ahead.
Yeah. Agreed. I think, the foregone, it's not a foregone conclusion that our systems make services a priority, and to establish the funding streams necessary to do that. When we're talking about public-private, I mean, I guess like so much of this is theoretical. So for one, public-private, well, there's private nonprofits. Uh, so the for-profit is the part where I get very uncomfortable with the use of of uh of taxpayer dollars. And I agree wholeheartedly with what Commissioner Wilkes said. And then the second one, yeah, so obviously we work with people who are businesses. We have vendors. The people who make the database, the people who, all of the things that we need. So, there is a mix in the housing field. I work with developers. But it's the idea that, these funds that are taxpayer funds that came from a tax on millionaires should not go into line the pockets of anybody. It should go to services and care. And but when I say it's abstract, like where's the there in that? Like, is there a proposal for a specific thing, and then we can actually look at it and see, what are the elements? Is it a for-profit thing? Is it like it's just, just as we would look at any proposal or idea to either fund something or study something, we have to look at what it is. So that's my comment.
Thank you.
And I think kind of like the spirit behind like result 2 is kind of like, how would we do this? Like how could this be done? What are the parameters? What are the things that we would need to be aware of as a commission to do something like to enter, just to even do that? What's the infrastructure? Because we don't have that infrastructure in place right now. So we would have, the work would be to explore how to get that infrastructure in place. Like, so that we're aware of like all of the laws and regulations and everything that we need to know before we would even enter into something like that.
I like that we were just exploring that, and I look at it more as a sustainability piece. That's when I see the private public, that there's a sustainability model attached to that, and that just to be open to it.
Yes, Commissioner Sy, I see your hand, please.
Can we clarify how result number 2 and 3 are different? I mean, I can see how they could be one and the same, and that when I read result number 2, I do think about sustainability, and then when I think about sustainability, I think about long term. And so, what is the distinction that we're making? I'm assuming we are making a distinction. So, what is it?
I think the distinction is, you can have public-private partnerships in general. It doesn't necessarily have to be for sustainability, but we could have projects that are public-private partnerships that we could enter into. I think one of the things that I think of is when I opened this meeting up and I said we have a broad advocacy role, but we're only financed for very specific things. But if we wanted to do more things, maybe we could enter into public-private partnerships to do more things outside of, the things that we're already allocated for. And I think number 3 is more specific of a specific interest that's come up with commissioners in terms of, the concerns that keep coming up on the, volatility of the funding of our public behavioral health system or just behavioral health in general. And so trying to think of like what can be done for that specific thing. Is it a public-private partnership? I don't know. But it's like number 2 could help figure out, a way to do number 3 or could support doing number 3. But number 2 could be other things outside of even a revenue stability thing.
Got it. Okay, thank you. That is helpful. And then for result number 3, it looks like the focus would be beyond BHSA dollars. Is that right? Because county behavioral health systems have various revenue sources. I mean, there's realignment, AB 109 generally county departments also receive. There's a number of other, but when I've seen revenue stability, typically that's referred to in the context of BHSA. So I guess my question is for result 3, is it mainly focused on BHSA, is inclusive of everything, in which case my question would be, the commission's reach on all the other revenue is limited, right? I mean, I don't think anyone has a lot of control over realignment in terms of it being based off sales tax and vehicle license fees. So can we talk a little bit about the focus of result 3?
Well, I don't think we have the specifics yet because I think that's kind of part of the project is trying to figure that out. Just from the conversations I've heard at the commission meetings, both at the full commission and the committee meetings, I've gathered that it's thinking pretty broadly, not just BHSA, but just in general for funding. And some ideas that had been thrown out was like, yeah, you've got your sales tax, VLF, vehicle license fees, that funds like 91 realignment. You have all your different things that fund the public behavioral health system. But once those funds come in, is there a way to and I'm not a finance expert, but it's like, is there a way to do something with those funds that come in that can help create stability over time. But again, caveat, I'm not a finance expert, but there's ideas that folks have in this space, and the result number 3 would be to get them out on the table.
Okay. I mean, I'm interested in hearing more. I think the ideas that I've heard around the revenue stabilization in the context of the commission has been around public-private partnerships. So I'd be interested in hearing like what other opportunities there are. Very open to it. I just am very interested in hearing more. Thank you.
Other feedback, questions from committee members on the results for priority 4? Yes, Commissioner Brown.
Thank you. Just to add to the discussion on this, I think it's important to understand that I don't think anybody's trying to limit this to any one particular type of way that we could leverage limited funds and through collaborative partnerships be able to make our efforts better than they can be with the existing funds that we have. And I think one of the ways to do that is when you look at other philanthropic foundations and organizations, they get hit up for money all the time for people. And typically they like to see whoever they're giving money to have some skin in the game, that they have some funding being put in of theirs, and not just be seen as a cash register for the requesters. And so, I think what's important is, I don't know what the exact projects are, but I do know that if we continue down the path that we are going, we're unlikely to get any better in terms of our financial position over the next 5 or 10 years. And if we could open our minds up enough to recognize that by partnering with other organizations, other foundations, other entities that have similar goals and similar concerns, that we might be able to leverage their efforts and their money and our efforts and our money as well. And I don't think anybody here is advocating, strictly for for-profit companies to do something. I think that the reality is that a lot of the discussions that were had already when this was being explored centered around large financial foundations and the desire for some businesses to put money into a donation or into a cause that that they believed in and wanted to see some of their funding go into, not necessarily a business arrangement. I'm not saying that couldn't be, but certainly some of the things that we saw as possibilities and discussed as possibilities in this area centered around initiatives and projects that were really initiated by government, by collaborative government agencies, banks, others that were not typically for-profit companies, I guess is what I'm trying to say. So I think the idea here is, unless we put this as a priority to explore this, we're not gonna know what the possibilities are. And I just think that there's a lot of apprehension about it. And to be honest with you, the amount of money that we're talking about, I mean, even trying to get a tiny bit of money, got people very defensive on the last round. and it's going to be a token amount in essence compared to what the potential is for it to leverage outside of the resources, the financial resources that we would have to offer. So, and you know, obviously nothing would be done until we discussed it and had a proposal and did all that. But I think the problem is that everybody that has come out against this is really kind of got a look of, you know, well, that's not the way we do that, or we haven't done that before, or and what I'm saying is, I think in this, frankly, somewhat dire financial situation that the state is in and is headed in for the next few years, in all likelihood, I think we have to think outside the box a little bit.
Thank you, Commissioner Brown.
Yeah, I mean, I guess, you know, again, it's just like the specificity and, you know, I mean, we took that vote because that was like we had to make a decision right then. So nothing's stopping us from talking about it, you know, until we have to make that decision again. And I mean, I've like my entire career has been largely, you know, foundation grants. So, you know, I've been on that. I've also given grants. So, you know, I'm very familiar with those processes. Um, I guess I'm sort of wondering about the skin in the game. I mean, obviously the foundations or the government entities where I've been a consultant are like that they have skin in the game of like what the specific project is, what their priorities for funding is. Um, and maybe yeah, so you know, we should talk about it further. If you're talking about something like the ability to raise funds elsewhere, I know that Calvet has a fund where monies that come from other administrative agencies, governmental or foundation, and I'm not sure if it's just like private funding, but foundation money can go into that particular fund and be used to fund, for example, right now, the grants are across the state for the veterans' mental health and for the house, some housing supports, from some legal services, some things like that. So that's, you know, that's a mechanism that I'm not sure how they did it, what kind of regulatory or legislative way they had to do that. But yeah, so yeah, I just, you know, I just don't understand like the specifics. Yeah.
Thank you, Commissioner. And all of that being said, as the committee members look at this priority 4 and the 3 draft results, if you have any other feedback on the clarity of these. Oh, yes, thank you. I see Commissioner Callan, please.
I think it will, once the Innovative Fund gets moving, I think we might have some opportunities to take a look at some private-public partnerships, just and see how that would work, because I think I just want to make sure that this is layered into that framework.
We will see what we get when that comes in.
Any other feedback before we seek any public comment on this, on these results for priority 4? Anything else? Okay, hearing none, I think we can move to public comment if the chair agrees.
Cody, do you want to open it up to public comment?
Sure. At this time, members of the public may request to make public comment on this item. We have 2 in-room public comments. First up, we have Ash. Go ahead.
Hello, Ash, they, them. I'm with Safe Passages and Remco. Thank you, Commissioner Wilkes, for grounding the conversation in the very values that I believe bring us all into this work, and for Commissioner Fairweather's supportive inquiries around it. And yes. I want to note that the concerns that Commissioner Brown referenced around defensiveness, yes, we are defensive of the funds that alter the courses of many, many lives. Moreover, we are welcoming innovation, and we are highlighting the integrity of the sequencing process here. We've observed that this financing idea and the priority 4 outcomes looks highly parallel to what was a proposal that was rejected for consideration with the IPF at the last full commission meeting. Then it was reframed as a concept in the Budget and Fiscal Committee meeting and now appears embedded within the strategic plan results under priority 4. Because when an idea moves from proposal to concept to strategic embedding without standalone evaluation, it can create the appearance of bypassing the normal deliberative process. If the strategic plan is aiming to define priorities and values, then specific financing structures, especially those involving public-private partnerships or revenue stabilization, we feel that in order to honor the integrity of this commission's mission, that they warrant independent review with explicit governance safeguards. As our executive director, Brenda Graylish, stated, we haven't yet looked at the laws and regulations around these outcomes specifics, so I'm wondering how it already belongs in the strategic plan. Thank you.
I think because the idea is to understand it better, to see whether or not it would be something we would even want to move forward with. So, so the goal is just to try to create space, or at least name it, so that it's very clear that everybody's working on it. So the goal would be to be transparent, and so having a process and having everything done in our public processes so that everybody's tracking. So, but that would be a big piece of it, and identify all of safeguards.
Okay, next up we have Sarahi. Go ahead.
Hi, everyone. Sarai again, she, her pronouns, MSW student, intern with Safe Passages and REMCO. Firstly, I want to shout out Commissioners Fairweather and Wilkes for their comments around sustainable funding and the caution in investing in global innovations, and then also y'all's comments previously about advocating for a holistic approach to mental health and behavioral health. So as like a social worker in training, I really appreciate that perspective because it's really important. And then I also wanted to say that California in particular has the 4th largest GDP in the world. So at the end of 25, that was at 3.41 trillion with the T. And so that is a lot of money, but yet our communities are struggling and we can't seem to like find funds for mental health services. And so I want to ask like, why is that? And why is there such an unjust and unequitable distribution of wealth? And so because of that, I really caution the use of like taxpayer dollars for like international trips and, trying to invest in like global innovations or like making the richer rich. I think we have to be very careful with how like funds are spent. And then I also want to echo the sentiments around, thinking of outside the box solutions and like perhaps looking into like divesting from like harmful practices and institutions that systematically and generationally impact people's mental health and behavioral health, and trying to reinvest those funds into things that are like actually community centered. And that's it. Thank you.
Okay, thank you. There's no more public comment at this time.
Well, I think that means that we get to go to the last agenda item, which is adjournment. I cannot believe it's 3:35 and we're talking about this. I mean, I win. I get an A+.
Yeah, good
job. So I think we are done with the meeting. We're going to adjourn. Thank you all for we want to appreciate the staff for all the work they put in getting ready for this, all the commissioners who showed up, all the members of the public who showed up and offered input. Oh, LRI, yeah, thank you everyone for all your work on this. It has been no small feat. I can't wait till the next one where we get to go even deeper.
Do we have a date for the next one? Okay, great. Thank you.
On the lookout.
Thank you.
Thank you. Thank you all.